Pakistan, I will give you a little background, is one of the third country with the highest maternal mortality in the South Asia.
Wow.
It's still 186 per 1,000 live births, and which is the saddest part of it.
So 186 moms die
per 1,000 live births. If you see the statistics in 2019 and even before that, surveys shows that it is the postpartum hemorrhage, which is the bleeding from the mother's womb after the delivery of the baby, which is the major killer. It is the number one cause of mortality, and it accounts for about 41% of causes of deaths in Pakistan. You see, if a mother dies, the baby who also loses the chance of her life, and it's only 35% of the chance for that baby to survive.
Hi everyone, and welcome to the Born Into podcast. I'm Isra, the CEO of Every Pregnancy, and I'm so glad you're here. This podcast is about something that impacts every one of us, but isn't talked about nearly enough: the health of moms. Each week, we bring you stories of courage, crisis, resilience, hope, and facts from around the world about what it is like to be a mom, or help a mom, or support a mom. And today, I am hosting this episode from the ground in Islamabad, Pakistan. In countries like Pakistan, too many mothers are facing life-threatening complications without access to early detection, culturally respectful care, or even the basic trust in medical systems that so many of us take for granted. Joining me is someone who's changing that. Dr. Sidrah Nausheen is an associate professor in obstetrics and gynecology at Aga Khan University here in Karachi and an esteemed maternal health researcher. She's developed groundbreaking ways to catch and treat problems like postpartum bleeding. She's helping families overcome vaccine fears during pregnancy, and she's one of the most respected voices in maternal health in all of South Asia. We are honored to have you with us, Dr. Sidrah Nausheen. Welcome to Born Into. How are you doing today?
Thank you very much, Isra. I'm so glad, I'm so excited to be here, and I'm so thankful to Every Pregnancy and to yourself for inviting me today to speak about the issues and challenges of maternal health in Pakistan. And we are here together to discuss some of the issues which we are suffering from and some of the groundbreaking results. So I'm really thankful. I'm really excited to talk about the maternal health in Pakistan landscape.
Okay, well, I have a lot more that I want to ask you about in terms of saving moms and babies' lives in Pakistan and the landscape here. But before I talk to you about any of that or go any further, I want to hear more about you, Dr. Sidrah. What made you want to be an OB-GYN?
Why I wanted to be on that.
What's your motivation to have your life's work focus here?
So as I said, it's my passion to work on maternal health because it impacts the families, it impacts the communities. It's the whole family. A healthy mother gives birth to a healthy baby.
Absolutely.
And a healthy baby makes healthy generations. So you are actually taking care of one mother, you are taking care of whole generations who are coming ahead. So that's the impact you create by improving the health of a mother. So that was one reason, and the other reason was that, as I said, it's a preventable. Most of the complications are preventable by simple interventions and timely interventions. So when I was an undergrad, I will tell you a story maybe.
Yeah, please.
When I was a medical student and undergraduate, maybe I think I was in a house job. I was posted in OB/GYN ward, and I was seeing mothers literally coming in, and this is, I'm telling you, 25, 30 years back.
Wow.
Mothers were coming. I saw a mother who was coming with heavy bleeding. She was 12th gravida. She has 11 babies at home. This is the 12th time she was pregnant, and she was going to give birth to a baby.
This is 12th pregnancy?
12th pregnancy. And her hemoglobin was only 3 grams.
3 grams
3
means
is a very severely anemic. She was she was all pale when I saw her. And she was near to deliver, and she had no antenatal checkup. She has not been taking any iron or supplements. She had the family was very poor, socioeconomically deprived of all these nutrients. So she came in, and she within next half an hour she did. So I was as an intern, I was rushing to arrange for her blood and everything. She delivered. We gave her 2 or 3 pints of blood, one after the other, but she started bleeding. and she bled so much. She was taken to the theater. She was, I mean, even after transfusion of the blood, because she was bleeding heavily, she went into DIC and she couldn't make it.
Oh, man.
And it was such a tragic event for me because, you see, if a mother dies, the baby who also loses the chance of her life, and it's only 35% of the chance for that baby to survive. So it's not only the life of the mother, it's life of that baby. And think about those babies who are left behind. There are 10 to 11 children. Who will take care of them?
Wow.
It's so tragic. It really changed the way I was thinking. I actually was passionate about surgery, and I was going to do a general surgery, but there and then, that was the moment I decided, no, khalas. This is the time I want to work for maternal health.
Oh my gosh.
I can't, this is not just one woman, this is whole family. The kids, they are left behind. Who will feed them? Who will take care of them? You know, and the mother in this part of the world, they are the last one to feed themselves. They will, if they have, they are the bread, in most of the families I know, they are the bread earners also. They are the bread earners, they are the bread makers. Whatever they will have to eat, they will give it to their children first, and the male child will get the first, the female child will get in the last, and she is the one, maybe she will sleep hungry, or maybe she will get something to eat, or maybe not at all, and upon that she is pregnant also.
Oh my God.
So she is sacrificing herself for the sake of the life of the family, and what happens in the end?
She loses her life.
Yeah, so that was a really a game changer for me, and I changed my career thinking that no, there has to be somebody. We all should come together to save the mothers. So that's how I started developing my interest in maternal health, and I started my residency in Aga Khan University. I'm a resident of this institute, and I'm privileged to be in Aga Khan University since then, for the past 30 years now.
That was such a beautiful and powerful story, but also so tragic.
It's so tragic. It's so
the pain,
tragic.
like,
and you know, nothing is more tragic than the death of a mother.
no, nothing.
It is not. It is so tragic. It is so tragic for the whole family.
And we know that, right? And like in our faith, we know the mom is in a revered position, and you have these moms here who I even saw this week carrying 11, 12, 13 pregnancies back to back, often with very little care. You know, in the case that you were mentioning, you know, Allah yarhamha, may she rest in peace, thinking about how she was delivering her 12th. You said she didn't go to any checkups. She didn't.
So this is what the
culture.
Yeah, so this is what the culture is actually. The woman, there is no woman empowerment. She is likely. I mean, she is sacrificing herself for the family, and she cannot think of herself, because and you know, the family spacing, the birth spacing, it's so less in our country, in this part of the world. Nobody. I mean, the whole empowerment is with the husbands and the men of the family. I think we should counsel them, and they should come across to think about it, because if there is no spacing, the life of the mother is at the stake, the nutrition of the mother, the nutrition of for the babies as well.
Of course, because if a mom is not healthy
the
when she's delivering,
the
how
whole
is the baby
family
going to
is
be healthy?
getting affected. So we should also focus on, this is I would say, the gun behind the scenes, the family, the contraception, which is not being practiced in this part of the world. The contraceptive prevalence rate is very low. It's only 30 to 35%. So we should work on that also. These are all the risk factors or the background factors which brings the mother to this stage where she collapses eventually.
Dr. Sidrah is actually one of our Every Pregnancy Champions ambassadors, who is out here literally identifying and representing all the work that we are doing in this world to help save moms and babies' lives. Let's give them a little bit of context here, Dr. Sidrah. We've been in Pakistan together since Monday. I arrived at 4 a.m. and we had meetings starting 9 a.m. in Karachi. We've been to 3 cities together this week, Karachi, and then Islamabad now, and then Lahore. Can you tell everybody what we've been doing together this week?
So this week has been very exciting for all of us, because we were exploring different landscapes of maternal and child health in Pakistan, as in Karachi, in Lahore, and in Islamabad. So there are different players, there are different key players which are working on the maternal and childborn landscapes. So we were exploring them. We were exploring where they are working. We are doing the mapping with them, and then we are in a position, because with every pregnancy we are making a consortium so that we can help out those mothers who really need it, the mother who are living in the marginalized areas, the mothers who cannot access the health care. We are there to provide them with the facility and with the needs they require actually. So I'm very excited for the whole week we have spent together, and I'm sure, and I'm glad, and I'm sure that we will reach some conclusion, and we are going to do something good for our mothers.
Well, I love that you're not sick of me yet after 5 days of
No,
having
I'm
me
not.
every single day. I have totally just completely been enamored with you and admire the work that you do, and taking us into these communities all week where we're seeing different types of facilities, from government-run public facilities and then private sector facilities. So facilities that are in the slums and then rural areas, but also in the urban settings. And we really got an incredible taste to be able to witness firsthand here at Every Pregnancy the work that is being done by incredible sheroes and heroes in the sector, but also hearing the stories directly from moms and hearing how they're impacted, what their maternal health is like, and what the services are to support them. And I didn't know so much about what was happening in Pakistan, and I'm really looking forward to this episode because I think a lot of our listeners also don't know exactly what's happening in Pakistan and how simple it is to save a mom's life, but also the tremendous need still, despite the incredible work that so many of you are doing. So thank you for taking me to so many places, giving me a firsthand experience where I could see with my own eyes and hear with my own ears, because that is invaluable. And I will tell you, overall, my impression of Pakistan is I love it. I think it's been an incredible country, and it's my first time here, and I am so grateful that I got to have this first experience with you and with your team. So I just want to give you and everybody that's been part of this week a huge thank you and a huge shout out to all that you've done for me this week and every pregnancy.
You are most welcome to this part of the world because this is a different part, and Pakistan being, I would say, from the maternal health point of view, I am very passionate about the maternal health, and many of us are doing work on that as well. So it's important to talk about maternal health because its impact, it is impacting the lives of the families and the communities, and it is very critical for the global health and development as well. So that's my passion because of its impact on the families. And the second thing is that most of the problems in maternal health are preventable.
Yes, absolutely.
It's preventable if we work together, if we join hands together, and we work for the betterment of the woman. These diseases, these causes are preventable.
Yep.
So Pakistan, I will give you a little background of that, is one of the third country with the highest maternal mortality in the South Asia. Wow. It's still 186 per 1,000 live births, and which is the saddest part of it.
So 186 moms die
per 1,000 live births.
Per 1,000
live births.
Wow. So 186 out of 1,000.
It's a huge number actually.
That's really high.
So we are at the third number in this low middle income countries. So we started finding out why the mothers are dying actually. So in Pakistan, if you see the statistics in 2019 and even before that, surveys shows that it is the postpartum hemorrhage, which is the bleeding from the mother's womb after the delivery of the baby, which is the major killer. It is the number one cause of mortality, and it accounts for about 41% of causes of deaths in Pakistan.
So 41% of deaths of moms in delivery in Pakistan come from postpartum hemorrhage, which is the bleeding out after delivery.
After the delivery, soon after the delivery during the process of delivery or soon after the delivery of the baby.
And you've come up with a method to solve it.
Yes. So it is such a high number. So this mortality is, so then we tried to find out that why it is not declining. For the past 10 to 15 years, when I was an undergraduate student, and today when I'm working as a consultant, I'm seeing the same situation. The mothers are bleeding. I mean, we couldn't find any solution to this problem. Although we had the evidence-based guidelines from the WHO, we had evidence-based guidelines from the RCOG, but everyone is working in silos, and the impact is not there. There are multifactorial reasons for that. But the major delays, the major three basic causes why it was not happening is, first of all, the delay at home. The community has to realize that a mother who is pregnant and is going for delivery needs a facility to be delivered where everything is available for her care. So there is a delay at home. Then second is a delay while they are taking the patients to the hospital. Their transport, the ambulances, those services are not very good. The roads are not very good. So second delays occur there. And the third delay is at the facility. When they come to the facility, these are everybody is going to tertiary care hospital. Yeah. So when they go to tertiary care hospital, it's already overcrowded. There are many patients there. So the third delay occurs there because there are less number of doctors and there are more number of patients to deal with. So that's a grave situation actually. So, but during past few years, by awareness, by education, somehow the women have started moving towards the facility. So we thought out that why at the facility, why the woman is not getting the care appropriately and timely. So what we found for postpartum hemorrhage or the bleeding after the delivery, another 3 delays at the hospital. First of all, there are 3, not the delays, but there are 3 challenges to it, I would say. The first challenge is that we actually don't know that the woman is going into heavy bleeding.
She's bleeding too much.
She's bleeding too much because up till now we were doing only visual estimation.
What is a visual estimation?
Visual means that we are seeing the blood on the bed, we are seeing the blood on the ground, we are seeing the blood on her clothes, on the napkins, and then we are just trying to calculate that how much blood loss is too much blood loss.
Yes.
But that is a very subjective assessment.
Absolutely.
I may think this is 300, you may think it is 500, somebody would say it is 600. So there is no specific criteria to say that, well, this is now enough is enough, that she should need the treatment. Mostly the midwives and not only the midwives, even the doctors, they realize when the mother is collapsing or when she's dropping her blood pressure that now she's bleeding a lot. So we thought that there must be a mechanism for every doctor to know that this much blood loss is now needs treatment, and this is critical, and she should be given that. So what we did we have done a trial actually, which is named by the name of EMOTIVE trial.
What does EMOTIVE stand for?
Yeah. So the first E is for the early detection. The first challenge, which I said, the first challenge was detection. So that drape is a plastic drape which is hung on the side of the maternal bed, and it has markings on it. Yellow line for 300 mils and red line for 500 mils. By the way, by the definition, I would tell you, postpartum hemorrhage is defined as the 500 ml of blood loss soon after the delivery. So this is by definition. If a woman is bleeding and if she has bled up to 500 mils, that means she needs treatment immediately.
Okay.
So when you estimate, actually, when you measure the blood loss, you would know that now this is 300 mils, now 400, and this is the 500. That's the critical level. Now she needs the treatment.
Time to have a treatment intervention away. And that's a simple mechanism. Yeah, it's literally a drape that
simple mechanism. For the past so many years, we were missing the diagnosis. Actually, 50%, more than 50% of the times, it was missed.
Yeah, because it's based subjectively on people's eyesight.
But
who would have thought this one drape could solve that?
So this one drape has actually made a difference between life and death.
And how much does this drape cost, Dr. Sidrah?
It's almost $1 or less than $1. It's
less than $1.
Less than $1.
I feel like this is an important point to reiterate. That less than $1.
Less than $1, and it is made in locally.
Yes.
Initially, we were not having that, but now we are producing it locally, and it's less than $1. It's cheap. It's such a low cost.
And that can save a mom's life because it tells the doctors she's in critical care now.
Because once she knows that she is bleeding and she needs critical treatment, she will start the treatment actually. So we need that awareness all over. We need that the healthcare workers. We need to provide that tool to the healthcare worker to know that, look, this is the critical level that treatment should be started.
Okay, so M.
So this is the first E.
That's E.
Then comes the motive. And I like this mnemonic because it's easy to remember for everybody. And even the midwife and LHV would know what the motive is. You will not forget it by the name. So M is for the massage of the uterus. You have to, Previously, we were doing all these interventions, but they were all discrete. We were doing one intervention and we were waiting for next 10 minutes to see whether it is effective or not. Then the second intervention, and then we are again waiting for, and that we were losing time. For hemorrhage, the first hour is the golden hour. The time is critical. The clock is ticking.
Yes.
You have to save the mother by the timely interventions. That is why now in this motive, we have bundled up all treatments together and make it one motive.
I love that.
So on one side, you start the massage of the uterus. The healthcare workers know how to do the massage because it causes the uterine contractions.
Yes.
And it curtails the bleeding. The bleeding actually stops.
Okay.
So once the uterus gets contracted, and then you start the treatment. O is for oxytocin. It's a famous drug which causes uterine contraction, and it is used, it's a life-saving drug for somebody who is bleeding through the uterus. So there's a proper method how to give it. 10 units of the oxytocin is given intravenously. Even a midwife can do that. Even a healthcare worker can do that. Then the next T is for the tranexamic acid. It's an evidence-based intervention. Tranexamic acid saves lives because it stops the bleeding. So tranexamic acid, T for tranexamic acid, IV is for IV fluids. She needs because she's losing blood down, so she needs more fluids to be replaced by that, the blood she's losing. So 500 mils of the blood of the drip should be run fast, and it should, and since the mother is having the large bore cannulas, it will go immediately within the next 10 minutes.
Right.
So it takes, and we have timed that these interventions, it takes only 15 minutes to give all them together.
The whole bundle takes 15 minutes.
The whole bundle. And the last E is if the bleeding still doesn't stop after 15 minutes, then you have to examine her, you have to escalate for the second bundle, or you have to think of referring the patient to other area by some other methods. But this motive is so critical that it stops bleeding for most of the patients. So when we did this trial in 8 public sector hospitals in Pakistan, 4 of them were in Sindh and 4 of them in Punjab, and these are all public sector hospitals where midwives are delivering within under the supervision of medical officers, and the consultants are also there, but most of the deliveries are taking place by the midwives and the doctors. So we saw that by implementing this bundle, the severe postpartum hemorrhage was reduced by 90%.
90% reduction.
90% reduction.
Oh my gosh. That sounds like one of the highest success rates of any trial ever.
Yeah, even more than that. So such a big impact by such a low cost effective intervention.
It's just simple intervention to understand.
It's simple intervention.
I feel like I could do EMOTIVE. I could launch it.
Yes.
I feel like at this point when I've seen all the interventions and I saw that there are these facilities that even have them in kits.
Yes.
They have them ready to go, like the cart with the EMOTIVE bundle, all the things you need.
So for implementing this bundle, actually, it's not just the drugs and the methodology to that. There's an implementation strategy also, in which there has to be. We made PPH trolleys and PPH trays, which were there in the labor room, and they were equipped by the medicines. They were IV cannulas in that. They have the drips in there. So this is the requirement that every labor room should have those PPH trays readily available in the labor room. So if a mother starts bleeding, it should be given there and then.
Immediately.
Except the oxytocin, which has to be kept in refrigerator. The misoprostol, these are small tablets which are given sublingually, or it can be given orally or rectally, and it's immediately cause a uterotonic effect. It causes the uterine contractions.
Immediately takes action.
Yeah. So it is very effective. Even a midwife can do that. It's very easy.
That's amazing.
So that trolley was being made. Then we made certain, you have to train them again and again. Every 3 monthly or quarterly, the trainings were ongoing. We made champions. We tell them how to do it. There was hand holding, and they were doing it themselves.
Yeah.
So that's the whole package, how it happened. So the results are phenomenal and remarkable. This trial was done in African countries also, in Tanzania and Kenya and Nigeria also. And in those, when it was done there, they showed a remarkable reduction in severe postpartum hemorrhage and mortality by 60%.
That's amazing. So we're seeing that this intervention
So
works
why there's a
anywhere.
difference in Pakistan? Yes.
Yes, it's higher.
So why it is higher in Pakistan?
Why is it higher?
Okay. So I'll tell you, most of our women who are coming for the delivery, they are anemic. Okay. Anemia is one of the major background risk factor for postpartum hemorrhage, because if you are anemic, you are more likely to go into postpartum hemorrhage. It is directly associated. And the woman who has less blood in her body, or hemoglobin is low, means that she has less compensatory mechanism. She will collapse earlier than a woman who has better hemoglobin, better nutrition, and better iron in her body.
Right.
So they collapse early. So when we were receiving those, and we found that almost 80% of population coming to these facilities are anemic. So it's a major chunk. It's a major chunk.
And those are the ones that you've tested even.
Yes,
imagine how many more women that don't get tested are anemic.
This is what we tested actually. So, and the other risk factors include the multiparity, many babies, the 5th baby, 11th baby, 10th baby. So the more babies, the uterus becomes more atonic or more relaxed.
Yeah.
So they have more chances to go into postpartum bleeding.
Or complications
anemia,
more generally.
Yeah. So when the woman comes with the risk factors of anemia and other risk factors, the treatment was started at 300 mils of blood loss, so that she may not go up to 500 ml, because she may collapse at 500 ml. So the treatment was started earlier. So that's how we get the results better than the African results are. So Pakistan is a pioneer in that, and we were the first country in the world who did this implementation also. And we have proved that you need not to wait up till 500 mils. You may start the treatment at little earlier, so that by the time the bundle is given, the bleeding should have stopped. The idea is just to stop the bleeding.
And the idea is if someone is presenting with factors, you're going to take the initiative as the healthcare professional.
Yeah, because she would not survive to bleed up till 500 mils.
Exactly.
So for her, 300 mils is more than 500 mils. Yes. She will collapse at 300 mils.
Yes.
So the treatment was started earlier, and the results were better with that. And we really had those phenomenal results after that. So that's how the results in Pakistan are a bit different from what African countries showed, and it has shown more improvement. And now still we are, as an OBGYN personnel, we are thinking that what should be the ideal definition of postpartum hemorrhage. Should it be 300 for anemic women and 500 mils for other women? It depends. Yeah. So these breakthrough results are because of the early intervention. Number one, early intervention, early treatment, and whole bundle is given in 15 minutes, and you still have another 45 minutes left. So if the mother doesn't stop bleeding, or if other interventions are required, then that can be done.
And you have the time to implement
you have the time to.
The next intervention after that would be the balloon tamponade.
Yes. Now you know.
I know now. I've become an expert on actual PPH intervention. And I truly think with the training under Dr. Sidrah, I could actually implement this. But it is that simple. And I want people to really understand that.
So if the bleeding doesn't stop even then the last E is for escalation, examination, to see if there are any tears that can be stitched on, or if she's still bleeding from the uterus, then we put a balloon inside the uterus, which is very easy to be taught, a very simple, cost-effective solution. And then it really, for the whole of my life, I have done so many tamponades, and I have never seen any tamponade to be failing. It's so effective.
But let's break this down for people. So a tamponade, people may think, oh my gosh, that sounds like an expensive tool. But really, you make your own.
Yes.
And you taught women how to make their own.
Yes.
So how do you make a balloon tamponade?
All right. So it's interesting, actually.
It's very interesting.
Because in other areas it's quite expensive. So we made locally innovative solution to that. We took a Foley's catheter, and we put a condom on that, and we tied it with a rubber band or a silk thread, and then it is just inserted into the uterus, and we attached a 500 mils of drip behind that, and the balloon would fill, the drip would go into the balloon, it would fill up the whole uterine cavity.
Yes.
And then it creates a pressure. The idea is just to create a pressure on something which is bleeding.
So if you have a suture or a wound, just like you do in your hand, you put pressure on it, and everyone can understand that.
If the bleeding here, you put a pressure there. So in uterus, you can't can't put your
can't
hand
put
for
your hand
all
in
the
there.
time. So this is a balloon, which is, it's just like a balloon.
Literally,
simple balloon,
like a water balloon.
Yeah, a water balloon.
But you're filling
so you
it up
put a
and
balloon
putting it in.
inside, you fill it with the water of 300 mils or 400 mils. It takes the
expands.
shape of the uterine cavity, and it creates the pressure on the uterine wall, and it stops the bleeding from where the vessel is bleeding.
That's it.
So that's really a miracle and amazing.
And every time you've seen it, you've done it, you've implemented it, which is probably thousands
This
at this
is how we
point.
teach to the others, and this is how people are doing. And I think this is such a simple strategy which should be taught to each healthcare worker who is dealing with the mothers who are delivering.
So, but Dr. Sidrah, you're saying, so you've done thousands of these. It's always worked.
It always
It
works.
always stops the bleeding.
It always works.
Which means it saves the mom's life.
Until and unless it's too late.
Yes.
Sometimes it is too late. They are reaching to us after an hour, because if the hour has passed, then the mother is bleeding and bleeding. So she goes in DIC. It's a disseminated intravascular. It's a stage where the white blood cells and the platelets are lost, and the blood loses its capacity to coagulate.
To clot.
To clot. So if it doesn't clot, the bleeding wouldn't stop. If somebody is reaching to the facility very late, then this would not work. Then she may need a surgical procedure, which is known as the hysterectomy, or removing of the uterus, because she is bleeding. We have to ligate the vessels which are supplying the blood to the uterus.
Wow.
And we have to remove the uterus. That is the last resort to save the life of the mother.
And yet, so many women still die from this.
Yes.
Even with the interventions that you've proven to be so simple, so cost effective, anybody can really administer it. Yeah. So what's the reason why women are still dying from postpartum hemorrhage?
This is what I was telling you, that these three, we are not diagnosing it at a proper time. Number one, it is only on the visual estimation. That is the early diagnosis is not there. And secondly, a lot of time is wasted in the treatment, where one intervention is done after the other, and then the sequential regime, we're waiting for another one. So bundling them up together would save the time. And third is the delayed referral. Because
like immediately, if it's not working in 15 minutes, she's
immediately
got to go
do
to
a tamponade and
hospital.
refer. So I have seen patients whom was referred from certain areas, because I'm in continuous collaboration with them. If they are sending the patient, they call us. So we say that just do a balloon tamponade and then refer. Many of the patients, they went back from the way. While they were coming to tertiary care hospitals, if khalas, the bleeding has stopped, we go back to our primary.
So because of the balloon being in there, as they were on their way to a hospital that could handle a critical situation,
they go back.
They go back because it worked.
Because the bleeding stopped and it worked.
So Dr. Sidrah, how many patients were in this trial? How many moms?
Yeah. So in this trial, we had 11,000 deliveries.
11,000 deliveries?
11,000 normal vaginal deliveries.
And 90% of postpartum hemorrhage
decrease. Yes.
Gone.
Yes.
That's amazing.
Severe postpartum.
Congratulations on that. I want to give you your flowers, though. I need to give you your flowers.
Thank you so much.
You are a trailblazer. It's such an honor to talk to you about this.
Yes. And also, not only the postpartum hemorrhage was decreased, there was no maternal death during the time period.
That's amazing.
The blood
Not
transfusions,
one mom died.
Not only a single one. The blood transfusions decreased by more than 60% because they were not bleeding, so they didn't require further blood transfusions. So blood transfusions were less. There was no referral to the tertiary care hospitals because they were managed in the same secondary care DHQs by the staff, and there was no referral once it was implemented. So the bundle can do wonders. It's wonderful,
and it's been doing wonders.
It's been doing
and
wonders.
You're taking it out not just around Pakistan, but you're taking it global.
Yes.
And I'm so grateful to have met you, back in December at the foundation when you came and presented to all of the Every Pregnancy partners about this amazing EMOTIVE trial. And you impressed everybody in the room. Everyone still is talking about you and feels so inspired by the work you're doing. And I think you've inspired more people to focus in on Pakistan. And even for me as motivation for Every Pregnancy, to be able to develop work inside Pakistan and develop a strategy in coalition with incredible Pakistani partners and organizations that are leading this effort has been such an honor in every way possible.
And we have been so thankful to Every Pregnancy and the foundation to take this step forward for saving the lives of moms and babies who really are in need of this strategy.
Absolutely.
And we need to join hands. We need support from the organizations to scale it up all over Pakistan, because in Pakistan you see the rural areas, there is a problem of access to healthcare to these women. They prefer delivering home. There are home deliveries by the TBAs, by the midwives, and the access to healthcare is an issue. So, and also in certain areas like Balochistan and far-flung areas of KPK and upper on the mountains, there's a difficult while traveling to the health facilities. So if some TBA or a midwife sitting in those centers knows how to tackle with this situation,
to implement the EMOTIVE bundle,
yes,
she saves her life, and the mom doesn't have to leave.
Yes.
You mentioned though contraception, which could be a buzzword for anyone listening to this in this part of the world. So I said it's very
family spacing,
right, but it's controversial to even say those words. And I think that what's really amazing about every pregnancy and the conversations we're having is that we like to disrupt. We like to disrupt the normal standards, the normal conversations, because we realize at the end of the day, our mission is to save as many moms and babies as possible. And this week we heard a lot about family planning and family spacing, which is a different way they use instead of family planning because of the taboo
spacing
culturally.
is a proper
spacing.
Word.
And I heard from many of your colleagues and the doctors and the facilities that they counsel women very gently.
Yes.
It's all about the approach and how they counsel them. Many women are coming directly to the doctor and saying, please help me, like space the babies, give me contraception, figure it out, but don't tell the rest of my family about it. Then you have others who are probably thinking it, but too scared to say it because of the family pressure at home. And so being able to counsel gently is changing that narrative a bit, but it's not enough, you're saying, because at the end of the day, it's still driving maternal mortality.
It's one of the risk factors, one of the major risk factors. Anemia is number one, I would say, and then the multiparity, many children's to one mother, pregnancy every year, lactation and pregnancy. And then they can't have the proper nutrition, malnutrition. Because they cannot afford those micronutrients to take. They can't afford to take iron, folic acid supplements. So these are all risk factors for that. Plus the socioeconomic environment in which she is living. Look about the woman empowerment. Look about the what she's getting to eat. The family size is about 6 per family, 6 children per family, which is very high. We are 245 million of population.
245 million in Pakistan.
And we will be doubling soon. So this is again a population bomb which is coming up. And then
highest fertility rate, you told me. In Pakistan has a very high fertility rate.
Very high fertility rate.
So a question for you, Dr. Sidrah. What do you tell people that use that argument of, no, she's, as a woman, her role, to be honest, have an honest conversation about it, because I think this is what these conversations are important, right? That a woman's role is to just carry children, whether they want to use religion or culture as the motivation for it. What do you tell those families or the husbands or even the women that think that this isn't my role and this is what I have to do, even if it's at the risk of my health and the future of my family, whether that be their nutrition or the mom's existence in the family with her continued pregnancies? How do you convince her?
See, that for this convincing is really challenging.
Yeah, of course.
So especially in different tribal pockets, in different areas. So there comes the role of education. And awareness. If the mother is educated, the girl is educated, and when she becomes a mother, and the family is educated, they will accept. They would know what do we mean. So the lack of education is one of the risk factors, because they don't understand the importance. They don't understand the importance of life of that mother. So when we say that work for saving the mothers, they may be because the families think that this is a physiological process. She has given 5 babies before, she can give 6 times also, but they don't know that she may end up in complication in any of the pregnancy.
Of course.
She can end up anywhere because she's producing every year, she's becoming more anemic day by day, she's becoming more nutritionally deprived. So she has to stop somewhere. So I think the husbands has to be taken into account. We should sit together with the husband, and the plan of the spacing should be made during the antenatal care. But again, the second problem is they don't come for the antenatal care.
Exactly.
So you have, once they are there, because WHO says that at least 4 visits. So I would say at least 4 visits, 3 visits, they should come and take the iron supplementation, or they should consult a doctor, so that one should know that she's suffering from a problem before going to the hospital.
And we
So
see these cultural challenges.
So prevention is better than cure.
Yes,
so prevention,
always.
prevention. So
And we saw
once we prevent that, the anemia, and we'll uplift the nutritional status of the mother, she will end up she will go in a healthy pregnancy and a healthy outcome. And she will have less complications. So these are all puzzles which are interconnected with each other.
They're all part of the landscape, because when you address an issue like postpartum hemorrhage or maternal health in the part of the world, and it's not just Pakistan, right? And I just want to make sure that the viewers and listeners understand that we're not just talking about Pakistan in a vacuum.
Yes.
Maternal health is a crisis everywhere, including the United States.
Everywhere. It's a
of all the developed countries, the United States has the highest maternal mortality rate, which is a shame.
Yes.
And so we see these issues happening for a variety of reasons. But one of the things that I was even hearing this week and observing were so many of the women, when you said they sacrifice themselves, they truly do sacrifice themselves. And even to the extent of after they deliver and all the different types of facilities, women usually, typically, are wanting to go home 4 to 6 hours after delivery.
Soon after the delivery.
That I couldn't believe that. So Dr. Sidrah, let me just tell you, when I gave birth, I can't imagine getting up after 4 hours and leaving the hospital. I can't even fathom that. I was in the hospital because of complications a little bit longer. But even then, even if I was totally healthy and had no complications whatsoever, to get up and walk out after just having a baby in 4 to 6 hours, so many of the testing on the mom, seeing the first 24 hours is critical, right? To see if a mom is going to survive and any issues that she may have. And I was looking at these moms, one of them even speaking to me, saying, yeah, I'm leaving. I've been here for 8 hours. And I'm just, I was just astonished hearing it. And of course, I'm mindful of, there's so many reasons, right? She has other kids at home waiting for her to be taken care of. She wants to get back to her responsibilities. She doesn't put herself first, so she doesn't think that there's a reason for her to stay for extra care or extra observation. So there's so much in this that is cultural. And I really, really appreciate the work that you're doing, because while you're doing the intervention and direct services, you're also changing the narrative and the behavior. And that was something that stood out as a theme this week for me, was the behavior change. And you're just saying we change the behavior of the husband, of the family, and even the mother-in-law. I heard this week a lot. Everybody in the structure needs to have their behavior changed. Any other thoughts that you want to share on that?
You would be surprised to know that there are many families who refuse blood transfusion even if the mother is bleeding.
Why?
They don't consent. They would say that no, this is there are different taboos, and there are different myths that we will not take the blood outside the family if it is within the family. But there are some who are not even taking within the family also. So again comes the role of improvement of her nutrition before, so that she should not end up in blood transfusions. So there are myths within the society which needs awareness. So we need multiple sessions through social media, through the television, through the radio, to increase the awareness within the community about the maternal health.
Yes.
And it's not only the maternal health, it's the health of that baby who is coming.
Yes.
So maybe we can counsel that, look, you save mother and save your baby who is coming into this world.
And you save the family then.
Yeah, and the whole family. So because if the mother is malnourished, the baby would also be growth restricted.
Absolutely.
And if the baby is growth restricted, and when she will become mother, her baby will be growth restricted. So it's through generations.
We met someone today at one of the facilities at Babood, one of our amazing every pregnancy partners, that are doing and building an incredible hospital out here in Islamabad. I want to give them a huge shout out, the maternal and child health hospital they're building. But someone in the conversation today even told us that her mom was anemic and she's still suffering from anemia related complications.
Yes.
And she's much older, like she's in her 60s, and she's still suffering from the anemia complications. So you are right that this is a cyclical challenge.
Yes.
And it will be generational. And it will impact generations to come.
Yes.
Dr. Sidrah, we talk a lot about maternal health being just the delivery or the antenatal, which means like pregnancy care, and the baby is in the uterus. But we don't talk enough at all, and I already know this, and this is a general comment for our communities all around the world, about mental health and the
Oh, yeah.
psychosocial support a mom needs.
Yes.
And especially, I think people use buzzwords like postpartum depression or anxiety and don't really recognize that a lot of women, majority of women, experience some extent of that or some sort of a variation of that. But many of them don't even know because it goes undiagnosed because it's not even a priority on the map. So what do you talk about? What would your reflections are on mental health and how we address it here in Pakistan?
It is one of the major challenge which is coming up because we don't actually address that issue. And there are many, I would say, out of 10, one of the women is suffering from either anxiety or a depression.
Wow.
It's not only postpartum, it's antenatal also, because of the size, the culture which we have and the environment in which they are living. Sometimes the environment of the home is so hostile that they cannot speak up for themselves. Again, the role of woman empowerment, woman education, and she was deprived of so many things that she keep quiet, she keeps to herself. And I know that many a times when they come for the antenatal care, and when we drill down and we ask them what are the problems she's suffering at home, why you are so quiet, so they do speak up. And they do need some treatment. So we have also done one study in which we found out that if the mother is depressed or mentally stressed out, it leads to preterm labor. The baby also delivers earlier than time. Preterm means it doesn't complete the time of gestation within the uterus, and it delivers early. If the baby is delivering early, the baby would be small. There are problems. There are risks of respiratory problems to the baby, the risk of infection to the baby, and the life of the baby will become at stake. So it's one of the risk factors for early delivery in the mothers.
Wow.
It's one of in the postpartum period, soon after the delivery, because she has gone through so much challenges, so much pain, and so much and she has to take care of the babies at home. She has to take care of the family. It brings up more. There's nobody to take care of her, and rather she is there to take care of everybody. It creates another pressure on her. So they go in postpartum depression also. So I think this is an area which we need to focus upon, and which we need to work upon. And if we try to find out, there will be much more incidents in the community, what we already know.
Yeah, of course.
We haven't worked on that. Actually.
Yeah, but this is something that obviously I think all these partners can expand on and thinking through as we're giving the direct intervention and direct services support, which is obviously to save the life immediately, then also thinking through the mental health and the impact of these challenges, because there are tremendous challenges that moms and families are grappling with here that, again, are not unique to just Pakistan, but obviously I think it is scaling at a faster speed here because of the high fertility rate and the fact that there are families, typical median average family size is 6 to 7 children, whereas in other parts of the world, like that's unheard of.
Yeah.
So Dr. Sidrah, can you tell us a bit more about any patients that have stood out to you in terms of moms that you've witnessed unfortunately pass, or moms that you've seen survive?
No, there are many who survived.
How amazing is that?
There are many who survived. And I will tell you a story. There was early morning, 7 o'clock. I was just stepped into the hospital. I saw a woman lying in front of me, all pale, white, and she was bleeding actually. This was in... postpartum. She just delivered baby at home, and the father and the husband they brought, and she was bleeding like anything. Wow. So when I saw her, oh my God, she was bleeding so much. So I had to arrange, because arranging the blood will also take time and everything. So I told the husband that, look, she's bleeding so much and she may need surgical intervention and everything. He said, do whatever you can. The father was standing there. Good. The father was just crying, and she was begging, like, please do whatever you can to save my daughter, because I have been to hospital. This was the fourth hospital I think he came. Everybody was refusing, and this is also a problem in our society. If the woman is bleeding, nobody will take that.
Why is that?
Because they are scared that if there is a maternal death, or if there is any complication, there is a liability, legality, and all those. So private hospitals usually don't want to take it. It's only the public hospitals who take, but the public hospitals are already overcrowded. There are so many patients, so they think that there will be delays there.
So this is the fourth facility he took her to as she's bleeding out.
And she was bleeding out, and she has bled so much. So I said, okay, fine. We had to take her in. So we had arranged, I think we transfused her 6 or 7 pints of
Oh my
blood.
God.
We took her for surgery. We had to, I think this was her fourth or fifth baby. So and the time for balloon tamponade was gone already because she was bleeding like anything. So I told the husband that and the father that we had to take her in. We had to perform a surgery on her because she's not, the bleeding has been a lot now. We transfused her 6 to 7 pints of the blood. We transfused her with FFPs. We did her
Wow.
hysterectomy, and eventually we saved her.
Oh my gosh. Dr.
And
Sidrah.
that was a moment I can't explain the feeling what we had after saving one life. It gives you such a great pleasure, such a great relaxation here, and such a great satisfaction that you have saved a life. And there are many stories like this, day in and day out.
Thank God.
After doing the tamponade, some are saved after the tamponade, some are saved after the surgery. So it's not because, and I would say that these are the lucky women who reaches to the tertiary care facility or a secondary care facility. Think of those who cannot reach.
I can't imagine.
There would be many who cannot reach. If they are luckily reaching the hospitals, we are there to save them. But for those who cannot reach, there are many who are traveling and they couldn't make it. And this was also this person brought it, I think this was the fourth facility we
Yeah, and that's why those interventions of learning how to do the EMOTIVE bundle could save that life that hasn't made it or hasn't even become
But she
close
has
to
been bleeding
hospital.
for last 2 hours, I think.
That's a miracle that you saved her.
Yeah.
And what an incredible story. So you've saved many lives.
So
Mashallah.
all people like me who are working in secondary or in the tertiary care hospitals, they do it daily. This is not my story. This is story of all obstetricians. They will witness to so many lives they have saved.
Dr. Sidrah, I got to see firsthand how your patients and your colleagues admire you so much. When you took me from your office building where you teach and you do meetings and you do your research over to the hospital, and I got to see in the ward itself how, like, this is Dr. Sidrah, she's here to do her work. I mean, what keeps you motivated with all the different elements? Because you don't just do work.
When you are a clinician, yes. So when you are a clinician or a surgeon, you can save 1 life, 2 life. I mean, the clinical load, whatever you have, you can save those lives. But when you become and step into clinical research or a maternal health or any, you step out into the community, in the public health, you save many lives. So through research like this research, we can save thousands and millions of lives because you invent a new intervention. So that intervention can save so many.
And you can apply it anywhere in the world.
Yes.
How incredible is this? Honestly, I feel like witnessing it in action. I want to talk a little bit about something I think is really important because you mentioned access to healthcare. Yeah. And that is obviously a challenge anywhere in the world, especially in countries where there's conflict, where humanitarian disasters are taking place. And I saw something really unique that I did not expect to see this week in Pakistan, which was, it wasn't just the facilities. Each facility has a team of people that are in the community healthcare workers, essentially, that are going out into the communities, into these rural areas especially, that are high concentration, where either moms don't go to the doctor because they have lack of access to get there, right? No car to get there, but also maybe their family doesn't want them to go. So then you have these workers going up and setting up stations that are close to people or visiting in their homes. This is one of the most powerful, I think, ways of addressing this because you can test out the anemia there in person, but then you can do the counseling, you can do a lot of the antenatal care there in the homes. Why is that model so important in places like Pakistan?
You see, because if due to some cultural barriers or due to distance, if the mothers or the pregnant woman cannot reach to the facility, then it comes our duty to reach to them. This is our community. So each tertiary care hospital has certain secondary care and then primary care facilities, which are like a hub and spoke model. So this is my dream, that one hub is having so many spokes. They should be responsible of teaching their spokes and the education of those, and going to the community and telling to those mothers and those families through the counselors or the visitors to mobilize them towards the primary care or the secondary care facilities. or then ultimately to the tertiary care. So this is a whole holistic approach which can be applied through proper planning and proper intervention, so that the families should be counseled. And there is a role of social media as well, because in this nowadays, with in the era of digitalization and
Yes.
mobile everywhere,
AI
I think
everywhere.
mobile phone is everywhere and every person have that mobile phone. So maybe small videos, small sort of social media campaign, like we are thinking of.
Yes.
So that campaign could reach every corner of the country and every home. And even husbands and mothers and fathers, they were looking at it, and they realize what is the importance of maternal health. I think the awareness is lacking, and there's a lot more role the awareness can play for saving those lives, which are for the care of those mothers, and as well as for the newborns and the babies as well.
And this is a very good segue into discussing how every pregnancy and you are going to be collaborating and essentially building a consortium of organizations here in Pakistan that are all committed. And, just to say, and I think you've known this very well, that we as an organization never want to be a typical NGO, and we really are not in so many ways. We're not a typical non-governmental organization or aid actor. We don't want to come into a community, implement interventions or solutions that we think work, and then come out, right? The parachute in, parachute out. And I think it's really important to recognize that the way that we're going to see the change happen and we're going to see maternal mortality get reduced in Pakistan or other places is it's got to be led by the organizations on the ground, by the advocates and champions like you, Dr. Rubina, all the different people we've met this week, an incredible group of people that are too countless to name, but to just say that they need to be at the lead in the forefront. And so as every pregnancy, we want to support you all in your efforts that you're already doing, your life's purpose and commitment and dedication that truly was so inspiring to see this week, from the clinics to the conversations we were having with partners at a roundtable and anywhere and everywhere in between. So what is, to you, the collaboration model that you're most excited about, and the collaboration going to look like in our future together, working with every pregnancy? How do you envision all this coming to life?
So first of all, I'm really thankful because to bring attention to bring the global attention towards the maternal health care in Pakistan. I'm really excited to work with all the organizations together on this aspect, and it should start as a movement, as a consortium. And we should all be working together towards save moms and babies. So how holistically it will look like, it would be like a movement in Pakistan, and everybody would be talking about saving mothers and saving babies. So it has never happened before, because different NGOs are working in their own space for different their logos and different aspects. But together for saving moms and saving babies, it has not been started as yet. So I'm really excited. I'm really thrilled to work for it. And I can see that maybe in few years we can bring a dent in the maternal mortality and the neonatal mortality. And if we could do that, we would achieve our targets.
Yes.
And we could save those mothers, and that would be such a great success for all of us, to save the mothers and newborns.
I'm so excited.
I'm really excited about it.
Sidrah, you've brought so much energy this week to me, and just being able to witness and learn from you has been such an honor and a privilege. For anyone who's listening to this, who wants to help, who maybe works at a hospital or in a government or at a foundation or nothing at all, but wants to help in this situation and helping moms and babies, what's one thing that they can do tomorrow to improve maternal outcomes in a place like Pakistan or where they live?
The global organizations, or
anyone listening to this?
So I think we need help of other organizations. We need the collaboration with all of them. So in whatever space you are working in, whatever work you are doing, I think we should all come together on that consortium, and they can, I think, donate on your page.
Yes.
If they want to give fundraising, we want to give our help, so that we can join hands. Whatever help you can give, that would be very important for us, and that would save lives. Actually, that will be served for saving the lives of mothers and newborns in Pakistan. So I would encourage everybody who is looking at it and everybody who can donate. So please donate generously, because every pregnancy, everywhere, every mother, we need to save them.
I love that. And also just even the conversations, I think we were even saying how we just need our community, in particular the Muslim community, everywhere to just be talking about moms and babies' health. Like this should be a conversation people should think about, should be curious about it.
Even a $1 can save life. I could say now this with confidence that your $1 would save the life of a mother, because it's so cheaper. And giving so many together, we will collect, and together we can do so much for this world. We can do so much for these mothers. Alone is difficult, but together we can do so much.
And this is a collective effort, because with preventable deaths, it's on all of us. It's a responsibility in any way you look at it.
It's a humanity. It's saving the humanity. Believe me, it's a saving humanity.
Absolutely. Dr. Sidrah, any final thoughts for anybody listening? Any final reflections that you want to share?
So I think the only thing which I feel is lacking is empowerment of the woman. We need to empower the woman. And if they are listening to this, I would say, please take care of yourself. Please put yourself first, because if you are there, you would be saving the lives of others. So you have to take care of yourself. Get that courage to go out to the hospital. I mean, if you are not speaking for yourself, it's less likely somebody else would do that. So for the health of the mother, for your own health and for the health of the baby. So they should speak up, and they should be empowered. So please take care of yourself. Go for your antenatal checkups. Go to the hospital for the delivery, and that is what is required, because we are there to take care of you once you are in the facility. And there is I would finish by saying, I just remember there's a famous saying in Urdu language.
Yes, please tell me.
That it's about hum maaye, hum behne, hum betiyan, qaumo ki izzat humse hai. And I will translate, we are the mothers, we are the sisters, we are the daughters, and the honor of the nation is from us. The dignity of the nation is because of us.
That is so beautiful.
And we need to save all of them.
That's so beautiful. What a beautiful way to end your reflections. And I have one prompt for you that I would love for you to finish the sentence. And if every mother in the world should have
healthy pregnancy and healthy outcomes and healthy baby.
I love
and
that.
Healthy generations.
I love that. That's beautiful. Great job, Dr. Sidrah. What an honor it is to sit with you. She's my new best friend.
Yes.
I'm sad to be leaving her today. I actually leave Pakistan later today after a whirlwind of a week. And if you haven't looked at our social media this week or want to see more of what we did in Pakistan, you've got to check out our social media or everypregnancy.org/Pakistan. Dr. Sidrah, thank you so much for your honesty, your brilliance, your commitment to saving mothers, and the work that you do every single day with such passion and energy and vibrance, which is what I was told a lot this week, and recognizing that you've shown us that it is not always about new medicines or more funding or more complicated interventions. Majority of times, it's actually about seeing mothers sooner, launching simple and affordable interventions, and just taking initiative and taking action, bringing families into this conversation versus alienating people out, breaking through silos in collaboration with other communities, and recognizing that it's not just an individual effort, but it's got to be a collective mandate that we all have a role to play in saving moms and babies. Every baby and every mom deserves healthy outcomes and a healthy life and future generations. Please, everybody give me a warm, I want to say thank you again.
Thank you very much.
I want to give you a warm round of applause for myself over here. But this is amazing, filming from Pakistan, recording this. Everyone, if you're listening to this podcast, please continue to follow Born Into. We have incredible guests coming the rest of the season. These conversations are timely, they're important, and they're critical for the world that we're trying to build, where every pregnancy is safe. Follow us at Every Pregnancy on social media and visit everypregnancy.org to learn more, sign up for updates, and join us in making this world a world where every mom and every baby has a chance to not just survive, but also thrive. Thank you all so much and have a good night.
Thank you.